Recording in progress.
All right, good afternoon, everybody.
Afternoon.
How are you? We waiting a couple of more minutes for some more people?
That sounds reasonable.
Okay. Just give me a minute to click in. Sometimes the internets are slow and things. Oh my goodness. All right. All right, we'll give it about 30 seconds. We can go ahead and get started. If that's okay with you, Brad.
Yeah, absolutely.
All right, cool. Well, I see a couple of familiar names up here. Not too many, but I'll just give a little quick introduction of myself. I'm Dr. Bret Barker. I'm a doctor of nursing practice and a family nurse practitioner. I have 18 years critical care experience in ICU, along with ED, med surg, etc. I'm one of those crazy nurses during that time who went to school for a total of 12 years of that and earned 5 degrees. I taught at a local community college out here in California where I got my first 2 associates at and trained over 200 nurses personally. Taught there for 10 years, left there as assistant director of the allied health program, then taught for your RN to BSN at CSUMB here in Monterey. So that was all fun, all while working full time in the ICU 3 nights a week minimum and teaching 3 days a week and going to school. So it's nice to have a little slowdown. I was doing some private practice, doing some OR circulating at Linfield Packard up by Stanford in 2019, working in urgent care, seeing about 30 to 45 patients a day with a scribe following me around so I could actually accomplish that. And then for my little private practice, I'm doing some aesthetics and things, and they shut us down in February of 2020. So I went back to the bedside as a critical care nurse and was in 6 hospitals in California during that year till February 2021. Wound up in Louisiana, NOLA, November of 2020. I was there till January, then went to Brooklyn. And then after that, I was done. Started working on my textbook back in June of 2020. Just a note, it was just, some typing in Microsoft Word to talk about what I saw, what was happening, communicating with people like Dr. McCullough and Vlad Zelenko and some others about what I was seeing and what they want to let us do and things like that. So back to the task at hand. So it's a little bit about me. The task at hand, I know this is about deprescribing. And the biggest thing I found as a nurse, the nursing route, is patient education. And I've found that people typically will do things if they buy into them. So if they understand a process and we don't hit them with big medical terms, they tend to sign on for things if they understand what's going on. And they, give somebody a recipe, they can usually follow it even if they have no cooking skills. So one of the things I like to talk to people about, and here's an example of the way I describe things, is can anybody here tell me in maybe less than 60 seconds, what is hemoglobin A1C? You don't have to raise your hand or anything, just jump in. So hemoglobin A1C, I see lots of patients come in and they say, well, my A1C is 6 or 7 or 8, I'm on this drug and that drug. And I said, well, did anybody tell you what this is? And they usually say the same thing, like, no. Hemoglobin A1C is a percentage of your sugar-coated red blood cells. So of your total red blood cells, when you have high blood sugars for a period of time, just like making rock candy, sugar will stick to them and crystallize. It's called glycosylated hemoglobin. Now, so that's a great measure to give us an estimate of what a blood sugar is over a period of time. The red blood cell lives for about 120 days. So, about every 4 months is probably the soonest you'd want to check a repeat A1C should they get on medications and do dietary changes and exercises and those things. And they say, well, what does that A1C do? What's it mean it's sugar coated? So I explained to them, well, a red blood cell is a little slippery, biconcave little cell that goes through bloodstream through the tiniest vessels, the capillaries, picking up CO2 and dropping off oxygen to our tissues. And it has sugar and things that get attached to it. Now, when the sugar gets attached to it, that little slippery sliding thing that's like a gummy bear now becomes a Sour Patch Kid. And the problem with the microvasculature circulation, so the tiniest blood vessels, the capillaries, is that hemoglobin A1C. Imagine taking that Sour Patch Kid and scratching the inside of that tiniest blood vessel. This is why we have problems such as diabetic neuropathy, right? Things like kidney problems. People wind up on dialysis. It destroys and scratches and it thickens what we call the basement membrane in those tiniest capillaries. And so those vessels get thicker. And that makes it harder for things to go across, such as sugar, electrolytes, and even gas exchange if they get too thick. So that's the biggest thing with damage. And I explain to people it's a long, insidious, and chronic disease. And so over time, you may have high blood sugars, but you may not notice it. So that's the reason to get a checkup. By the time there's damage, undoing the damage may be too late. There's still things we can do. You don't want to just keep going down the cliff just because you're on the slope. So that's an example of how I train patients and talk to them and teach students. People say, well, why is sugar such an issue? Well, I'm a personal believer. You can agree with me or not, or disagree. It's fine. But the food guide pyramid's been upside down since its inception, right? For probably millions of years, human beings, once we started getting intelligent, eating meat and fat, the fat to insulate the nerve pathways in our brain and other parts of our body, and the protein for energy made us highly intelligent, and didn't really eat a bunch of sugar. And we all know over the last 100 years, they put sugar in everything. It's a great preservative for things. So is salt. We all need salt as well, but too much sugar just is not good for us. And I talk to people and they say, well, if I eat fat instead of sugar, it's going to make me fat. I said, well, no, fat doesn't make you fat. Fat usually does. You might get a transient increase in your cholesterol, but our bodies are designed to process fat, just like burning gas in your car, hydrocarbon. So when you have too much sugar in your body, the other problem that happens is your cholesterol is likely going to go up because you're eating so much sugar. And people say, well, but that sugar is not a fat. I said, well, your body in your liver, you're going to make the sugar you need. It's called glycogen. It's going to be in your liver and it's going to be released to your body. Your brain can't store sugar. You can eat all the sugar you want, and you can fast for a couple of days, and your liver is still going to produce the sugar your brain needs. The oxygen's a different story. You still have to breathe. And people say, well, still, how does that affect my cholesterol levels? Well, I bring up an analogy like Amazon. Anybody ever order an Amazon package and you got it, and everything's tightly packed and everything is in the right size box, and you open the box and you pull all your stuff out and oh, this looks great. Well, that's high density lipoprotein. So the sugar, the proteins, all the little components of the cholesterol molecule are tightly put away in there. So it's easy to transport out to the tissues and then be used by the tissues. Well, if there's too much stuff, whether it's the trans fats where the body can't really utilize it because it has molecules going in the wrong direction, or some machine put the hydrogens in the wrong spot and can't process it as efficiently, they're just going to start throwing this into a box and then throwing a couple of those little air packs, so it's a little bit bigger. So you get the big box with maybe 2 or 3 items in the box, and you say, why did they pack this in such a big box? Well, that's your low density lipoprotein. It's kind of a sloppy big molecule that's not efficient for delivering materials to your tissues, like a construction site showing up a big flatbed truck with 1 cement bag and 2 2x4s. And then it gets worse when you get to the very high density lipoproteins, where they just put 1 bag of Skittles in a refrigerator carton, just to be on the extreme of those things. So that's one of the things I talk to about people. So I do like to talk a lot about diet and exercise. I do like people to be on more of a high-fat diet, moderate protein, and low sugar, not just for reducing blood sugars, but inflammation and for energy. They need to eat less. It's great for weight loss. People do not have to go into a straight ketosis. I'm not a firm believer in that. Again, the keto flu and all these things, some people like to do that. But if they are a little bit more patient and go over time, they're going to start seeing results. I try to keep people from chasing the scale, as it were. It's nice, just like we do with people with CHF, try to do their weekly weights or if they're very severe daily weights, but about the same time every day. A lot of times with weight loss, the weekly weights are better for people because they're not looking at us, not staring them in the face. Okay, so that's a little rundown, just a little bit about blood sugars and cholesterol and things like that. Anybody have anything they want to talk about or ask me any questions? Somebody's curious. It could be anything.
Sonia, can you hear me?
Yes, I can hear you. Thank you. No, and I've known about that upside down food pyramid for quite some time. So I'm listening. I'm agreeing with everything you're saying.
Thank you.
I know that's a big issue. And I remember my father was a physician OBGYN telling me decades ago, before I even went to medical school, talking about that. And then I remember, going through my career, I'm a pathologist, retired pathologist, and just, looking about that. And then when I was pregnant with twins, and I ended up being an insulin dependent diabetic during the twin pregnancy. I guess my pancreas was big enough for one, but not big enough for two. So I noticed that if I ate according to the American Diabetic Association guidelines, what I should be eating at that point, that my blood sugars were way out of control, like Oriental food, with rice. And when I ate not that way, the opposite, I was able to, be okay during that time. So then that really, solidified my ideas about that.
Awesome. Thank you for that.
Mm-hmm.
Well, definitely the high glycemic index foods do that, but that puts people on a roller coaster. And just like anything, whether you're smoking a cigarette or taking in some caffeine or some other intermittent dosing, you can call it, sugar's the same way, especially with potatoes or rice or things like that. So having the balanced diet. I mean, it's hard for me to do too. I like my Hostess every once in a while, some ice cream and
Right.
stuff. I just don't eat a ton of it. Personally, 2016, I was diagnosed with AFib flutter. Very healthy most of my life. During that time, I was a lot of school, a lot of work, not sleeping right, and having my pie and ice cream at night. My cholesterol was going up, and my doctor put me on statins, and it made my heart hurt.
My mother died. My mother died from the what do you call it? The Pick's disease, dementia, which it started when I look back and started when she had a inadvertent overdose of statins, and she didn't even need the statins. We have a genetic high cholesterol and high LDLs, high HDLs and all that.
Right, and that's one of the things I'm going to talk about too when I talk about guidelines.
Yeah,
And
I also
labs and
have too
stuff.
many. I also have too many PVCs, the premature ventricular contractions triggered by anxiety and stress, which I've had too much of over the past 10 years or so. And sugar does trigger them.
Right.
It really does. It triggers runs of those. So I'm going to sign off because I'm in my basement crawling around listening.
Okay. Alrighty. And I'll just talk a little bit more about that stuff. So on the AFib flutter, they put me on Crestor. She did, and that was fine. But it made my heart hurt worse. So it wasn't even the AFib that felt more like anxiety. It was the flutter. Having the 3 beats in the atria for every ventricular beat, so I could hear my heartbeat like Edgar Allan Poe at 3 a.m. It felt like I ran a quarter mile or something, and I wasn't even out of bed. That was miserable. So my wife at the time was doing a keto diet, and so I started trying a higher fat diet, moderate protein, cutting the carbs. I never went into ketosis, but I started losing weight, and in 3 months, my cholesterol numbers were perfect, and they have been ever since. so, um, I'm a believer in it. I don't believe in this super strict thing. If I've got to look at 1 calorie versus 2 calories, then I should be in ICU if I'm that fragile. I just try to moderate it. It's just education, paying attention. I split portions with my wife. Still, if I'm not that hungry, I just don't pig out, and I think that helps a lot of people. When she's talking about the PVCs, and we'll talk about permissive hypertension as well. Some of the things that happen. I met this old ER doc. Did some interim stuff. This King City ICU. That a buddy of mine was a supervisor down there, so I went down to help him. ER doc was great. It's just like, here's a flow chart. He was showing the other ER nurse. It's like, okay, why are you here? That was the top box. And the second thing says, will this kill you? And if you said yes, then okay, we're going to put you in. If you said no, you went back to the top box. Why are you here? And so it's kind of not to laugh at death, but it's that same kind of line. So multiple PVCs, and the A flutter was driving me nuts. Okay, so it was enough to bother me. So I hit threshold. I educate my patients. Okay, you get sick and you start feeling bad, and you come up and you're going to hit a threshold that's going to spark you to seek treatment. Okay, and got to continue that treatment for a longer term than as prescribed, so that you can get better. As we see with people like with antibiotics for sinusitis, they take 3 days worth, they feel better, they fall below threshold, they stop, and then they got them in the medicine cabinet for next time they need it for whatever hangnail. Who knows what they use this stuff for, or they rebound their sinusitis. So something I like to talk to people about, okay, if this is bad enough to bother you, let's do something about it. But if it's not bothering you, or if it's not going in a direction that's going to harm you, you're probably okay. You should watch it. Right? This is our wait and see. We don't have to, change the tires every time we put exactly 10,000 miles on them. Stuff, according to many guidelines, like with hypertension, for example, they want everybody's being treated for high blood pressure now since they changed the number. The VA, when I was doing, even when I go there now, they're still at 150 over 90 before they even look at you. They're like, okay, that's fine. The civilian population, they're still looking at 130 systolic. And what I do see out there a lot with guidelines is people don't understand that word. Guideline is just that. That should be a starting point. That should be a recipe. Anybody here like to cook and alter recipes to their taste? I do. I hardly even use recipes half the time, but I have a general idea, and I like to make things that taste good based on what I want. So having a basis of where I should start and where I should go is ideal. And when I get patients in, when somebody comes in at 150 over 90, I'm not going to start them in a treatment for 130 over 80. Sometimes you got to meet your patient where they're at, and you need to start a little bit higher up on their protocol. I hate the cookie cutter stuff, but the guideline saying, hey, this is what you should do, instead of bringing them back every month with no results because we started too low with the medication. And when you see a lot of common things commonly, you get a pretty good idea of where a person should be. And, fortunately, spending enough time in the ICU, 12-hour night shifts, I sat in front of a lot of pumps with a lot of different drugs titrating. And I can see the effects of the drugs, whether, something to create an increased blood pressure or decrease the blood pressure, or remove arrhythmias, etc. So I do have the benefit of being able to tweak people and titrate them on oral medications a little bit easier. And I've gotten some pretty good results, probably a lot quicker than the general type of prescribing per guidelines. So there should be some adjustability based on where the patient is at, especially when you get to combination issues, which we all see with metabolic syndrome. We know that I did a paper in 2014 about obesity. It was about childhood obesity, but I looked at adults, and the hypertension, obesity, and diabetes has doubled every decade for the last 4 decades. Over half the population fits those categories, if not all three. So there's a lot of change. A lot of that does come from sugar, sedentary lifestyle. We have horribly low vitamin D levels on just about everybody. Everybody's wearing sunscreen, living under fluorescent lights and tinted windows. And just, I don't think I've ever seen one normal first-time patient come in to a clinic and have a normal vitamin D level. So that's just an example of some of that stuff about guidelines. Let's see, anything else? I want to talk about permissive hypertension or just treating hypertension? Sure, Sonia.
Just a little comment. Like I said, I'm a retired pathologist, but the, people, neighborhood friends think, I'm their doctor, which I'm not. But what I collect so many stories of them coming to me, no matter what the issue it is. It's after an injury and anti-seizure medications or the statins or whatever the issue it is. I just see so much in the establishment of this knee-jerk reaction, treating a number. My friend.
Right.
prostate cancer after the shot, unfortunately. But he goes to the doctor. They do this well check, right? For Medicare, they do this well check. Well, what are you going to take the test for if you don't look at the results? So I look at the results. They say, oh my goodness, you have to be on a statin because you have this, whatever it is, high cholesterol. But you look at the calculation, it says he has lower than normal cardiac risk because he's so trim, so thin, high HDLs. So the doctor wants to put him on that. And then I look and his kidney function's a little bit off. I said, oh, we're going to give you a pill for that. I said, you have to drink water. So he just drank water for a few days and everything returns to normal. And so many people are coming to me saying, it's not working. I go to the doctor. All they want to do is give me a pill. I don't feel good. I can't talk to them about it. They won't listen. So I have a lot of friends and neighbors who by themselves titrate themselves off prescription drugs and their lives change. You can't get off of it, all of it, but it really makes a difference. My ex was an osteopath. He is an osteopathic physician and was so good about the deprescribing. All patients, no matter what, he would say, what are the 1 or 2 or maybe 3 medications that you really need and get rid of all the other ones. And patients do better. So, but we all know that. But, these are anecdotal stories, but they just never end.
Sure, and I find a lot of times people think they know what they think they know, and so you just try to educate them. I don't hold that against them. Don't even really correct them. I just explain it from a scientific point of view and matter of factly in general terms with the analogies and things like that. But you're absolutely right. It tends to be with society, oh, this is wrong. Here's a pill. That's why there's so many prescriptions and things. Instead of, oh, well, we can do this pill if you don't diet and exercise. Here's a cheat on diet. Here's a cheat on exercise. This is why you can think. Unfortunately, with the mainstream, the diet sheet they give is a food guide pyramid. And that's almost cussed right there. And it's just going to make the matters worse. So I do talk to them a lot about those things and getting up and getting active. Nobody has to go to the gym and try to turn into Arnold Schwarzenegger. That's not going to probably happen anyway. But they need increased activity of some type. Even if it's your brain activity. It's great to prevent Alzheimer's, physical and mental activity. I did a research study in 2003, I think it was, talking about brain-derived neurotropic factor, which comes from physical and mental exercise. It's really good for you.
And keep the
Brain burns
stress down.
calories, right?
Keep the stress down. Being calm. That's a big thing. I think my mother's, besides a statin, it was an emotional stress. That's just a killer for your body.
Completely. And I want to talk 2 things, and before I forget, I'm just making a note here. But you're right, like with UTIs, somebody comes in with UTI symptoms, we're going to take a sample, we're going to treat them, right? We'll do the CNS just to make sure we use the right antibiotic, but we're treating them anyway. We're not going to wait 3 days for the test, right? I'm not a believer in treating the numbers. Look at the patient. I mean, I like to mess with my students when I was teaching nursing. They go in there and I have the patient brush their teeth. I go out to the monitor and say, you see that? And I go, oh my God, what do we do? So, yeah, it's very serious. It's a Colgate rhythm. They say, what? They're brushing their teeth because it's bouncing all over the place. Like, you don't just jump because you see something. You have to think for a minute. If it's really, yes, you absolutely do. You can be thinking about it on your way to double check. Oh, they're just brushing their teeth. That's fine. But don't just treat the numbers. Right? You don't go run and do CPR on somebody with a 70% stat who's in there talking and, because the O2 sensor stuck to the bed frame, because I've seen that enough. But coming to treating number, here's a little thing that happened during the pandemic is spike protein causes inflammation clotting. This is all detailed in my book. And I'd walk into these rooms in these hospitals. They have 6 or 8 sensors on these people, and they couldn't get a reading. And they'd be 72, 87, 91. Oh, there's a good one. 42, non-life form viable O2 sats. Right? They're not real. And it's because those little microemboli don't carry oxygen anymore. So that little sensor hooked to the computer can detect oxygen on a red blood cell if it's there. If it's there, it's 100. And as that flow is going by, if you get a bunch of little sporadic clots, it's going to dip up and down, and it takes an average, and you get a reading. It's an inaccurate number. But they're using that to put people on ventilators, of course, give them remdesivir, let their blood clot out floor, and kill them from stasis in their bloodstream. As one part of this stuff. I would be told, well, they're not clotting up. And on more than one occasion, we draw blood on a patient, and the test tube would clot up. Oh, it's a bad test tube. So you need to use what you see. Don't just treat the numbers. Use what you see. And it was an argument, and TPA absolutely worked. I accidentally, had to clear PICC lines on patients more than once, but in the next next morning, their O2 stats started to stabilize as well as go higher. We were able to lower PEEP, so we weren't blowing up lungs and doing all these other things. And I've had more than, I don't know, about 40 different patients, through the end of 2021, call me from their hospital room because they got my number and they said, I'm 86% sat right now. They want to put me on a ventilator and give me this, remdesivir. And I said, well, you're talking to me. So, oxygen, if it's 100 down to 90, that's about the curve you're going to live in. Once you're below that, unless you're a bad COPD or CO2 retainer, you're out. So it's not real. I'm like, what? It's not a real number. But they want to treat me for it. Well, it's not a real number. I'm telling you, you're talking to me. You would be mumbling if you could even do anything. If you've been taking care of enough overdose patients and things like that, they just don't have enough oxygen. So, but yeah, I saw a lot of treating the numbers. I actually had in Brooklyn, they shut down a room because they said the monitor was broken. They could not get it set on this patient. And I walked up and I put my finger in there and said 99. I was like, it's not broken. The patient's broken. But yeah, there's too much. Yes, we need numbers and reports and labs and all this stuff to verify, but it shouldn't take away our critical thinking.
The other thing I noticed is that drugs, pharmaceuticals are given for way beyond the time frame that they should be given. Instead of a 6-week dose of the what do you call them? The proton pump inhibitors for the acid, or the
Right.
what is it, the finasteride for the prostate. They're only limited. They're only supposed to be given for like 6 weeks, 8 weeks, or whatever, and then they're carried on for years, and then the patients end up with horrible complications.
Lots of things. Even you see that with laxative, chronic laxative use, and people end up with self-inflicted negative colon because they think they're like my father-in-law, rest his soul. That was his thing. He needed a poop day once a week, and he basically stretched his colon out so he couldn't do anything but have a poop day once a week. The stuff stops working. Is the point. So you're absolutely right.
Yeah, I'm concerned about the proton pump. Is that what they are? I'm a pathologist. I don't prescribe these. There's one for the
some of them, things like
right?
PPIs like protonics and things like that are proton pump inhibitors. Things like famotidine are actually H2 antagonists, so more of an antihistamine.
The ones that were supposed to cut down the stomach acid, I remember as a pathologist, I'm starting thinking about that because I'm seeing all these gallbladders come out, and so many of them that aren't diseased. They claim that they're, it's the lack of mobility of the gallbladder. And there are sometimes the patients did show those studies and did show that. But it seems that since the advent of the widespread use of those drugs, instead of having squamous carcinoma of the esophagus, we now have adenocarcinoma of the gastroesophageal junction. And it turns out that, from what I understand, that bile is actually kind of carcinogenic, but our stomach acid neutralizes it. But if you keep interrupting that, then you have that bile flushing back there and you cause those problems. But those are only supposed to be used short term, but then people are on them for months and months. And when I asked those questions, I wasn't allowed to ask those questions.
That's because nobody has the answer. Because they don't think about the things you just talked about. And I find that to be an issue. Like when we have somebody in ICU, we don't want a stress ulcer in their stomach because they're MPO and things like that. Absolutely, I would use a PPI. But you're right. You have your stomach. It's the pH of 1. We all know. It's a very powerful acid, and the body's put together to deal with that as it's supposed to. And anytime we start doing better living through chemistry, we're going to throw something else off. I talk a little automotive stuff here with people. So, you blow a radiator hose, right? You go in the radiator blows, but it was your water pump, and the guy does a water pump, but he doesn't check the radiator to see if it's clogged, right? So he puts a new water pump and a new hose on. Next thing you know, you're blowing the radiator because now you got a hose that's tight and a water pump that has appropriate output. So you have to look at the whole system. And if it's not broke, don't fix it. Sometimes you need to do things temporarily.
That's the main thing.
Right. So just like with hypertension and things, it took people time to get to that, but that doesn't mean they're going to be hypertensive forever. I've had, especially even with people with old pipes, as they get older and, they have high diastolics because of just, clogged arteries and things like that. And you can't get their diastolics down. They keep throwing things to drop their systolic. And you
But
get
it's a
people-
compensatory mechanism. Our
Right.
body compensates for the things
Exactly.
going on in the body. And if you were interrupt with that, that's why, yeah.
Right. So, so your body wants to maintain some pressure in it, 90, 100 diastolic, because, they were living at 150. They're awake and alert at 140. They hit 130. They're starting to get dizzy. You take them down to 120. They're falling off the toilet, almost ready to crack their head open. Then you get a bleed. Yeah,
Yep.
I've seen all these things. I've taken care of these patients, and you just look at the number of drugs to run because they've got to do a med rec when they come in. And it's like, wow, they're on these things. So somebody with hypertension, there should be a plan. Hey, we need to start treatment. We need to do diet, exercise. We need a plan so that in 1 month, 3 months, 6 months, we can start looking at getting you off of these things so you're not on them the rest of your life. You don't need to be if you make changes. If you want to be, that's your choice too. I'm not going to tell you what to do, but I'm not saying you have to. It's really, you have to do something about it, not just take a pill. And that seems to be the hard thing these days is people doing the work.
My dad was dying in the ICU after a heart attack. He lived like 9 months, but they put him on a statin. I'm thinking, what is that going to do?
Make the numbers look good. Have you ever taken?
Well, they can charge for it, I guess.
They
I don't
can.
know. It's a protocol. They check the box, but they just check the boxes without thinking. It's like,
May I make a comment?
yeah.
You know what? Because I've been listening to so many good points, especially is your name Sonia?
Yeah.
Good points. And Brett, is it right?
Yeah.
And it's funny because you're like, you can't just take a pill. You got to do the whole thing.
Right.
And you know what the truth is? The whole thing is the mystery to people.
Right.
Mm-hmm.
Nobody explains it to them. They don't have time to.
That's the training a lot of us that we don't receive in medical school about lifestyle and about what the whole thing is. And now when you get out there, there's so many different diets and approaches. That was one of the things, I was an allopathically trained dentist and we learned the food pyramid and learned things like that through our training too. And it seemed to make me feel like I was falling short in being able to advise people about dietary things. Do you know what I mean?
Right.
Mm-hmm.
And so much of the things you're talking about the gallbladder, those are lifestyle things. It's another place where we don't always have that opportunity to get in close with people and find out why those things are happening. That's been my experience. I'm a dentist, but then I went back to school and got a naturopathic degree. So it's like understanding the other side of all the symptoms we're trying to treat. There's a body and trying to work there, and there's food and rest and all these other things taking part in what the output is. So, and it's such a good point. Really the drugs, a lot of them are intended just to be quick things to kind of correct something that's off.
Right.
And because it's typically the most we have to offer, people just are on them chronically, and then they don't take the time to look into it. So I've enjoyed your presentation very much.
Thank you. No, definitely. Food is medicine. Now, if you look prior to World War II, when they started making potato chips and candy bars and all that stuff as mainstream food, that a lot of soldiers started bringing back and making it mainstream. For millions of years, we didn't have all the weird diets, and people did just fine. So it's also complicating something and it's like, counting my macros. I had 1.2 grams of carbohydrates. If you're that fragile, you need to go to the ICU. It's okay. Have a Snickers once in a while. It's okay. Just don't eat 10 of them, right?
All those people were on, typically you're talking about all those years, they were on some sort of an ancestral diet. Ancestral diets lacked all the processings. It seemed like that was Dr. Price's work. A lot of the processings in food seems to cause a lot of the degenerative diseases, diabetes and cancer and gum disease and these types of things.
Right. So, example, olive oil is not going to kill you. It's great energy. It's good for you. Lots of good stuff in it. But if you take some other vegetable oil and modify it, or some plant oil that's, some synthetic whatever, a lot of things, if we got time, a lot of people don't even understand what trans fats are. And they started calling them trans fats because it's easier to understand than partially hydrogenated vegetable oil. So basically what they're doing, instead of the body, which is designed, all the animals and things are designed to take, here's the carbon, attach the hydrogen here, skip one, skip two, attach a hydrogen here and the other side of the carbon, skip one, skip two, and you got your polyunsaturated and your saturated fats. And then when some other natural being, like a human, ate that, your body had the enzymes to break that apart because the molecules go in the right direction, either levo or dextro, right back to chemistry. and it could break these things down. When you put stuff in a vat and just randomly throw hydrogens on something you don't know where it's going to stick, it's going to look like butter. You're going to call it margarine. It's going to look like butter. It's going to taste okay. It's going to have the right consistency and everything. But is it actually okay for you to put in your body? The same with like artificial flavors and things. You still get the ester of something like a strawberry or a pineapple ester. I'm talking about pineapple, for example. You eat pineapple, you're going to get bromelain. It's great proteolytic. It's good for your digestion, etc. But pineapple flavoring does not have those chemicals in it, right? So all the
Right.
processed foods and everything that are fake, they don't have the health benefits of food.
Yeah. And today you got to be like worried about cricket flour putting your bread
Oh.
flour or something. It's getting extreme. It's not just finding some red dye in there, man. You may have something really bad in your food now.
Right. It's like,
So
okay,
yeah,
yeah, the
it's
animal
hard.
eats the grass, it concentrates the iron and the iodine and the B12 into the meat, and then I eat a steak. And I'm good. And I get the fat and the protein and everything else, plus trace minerals and all this other good stuff. But virtue signaling, oh, that's horrible.
Hey, Dr. Barker, thanks so much.
Thank you all.
Appreciate your presentation.
Thank you all. Nice to see everybody.
Bye-bye. Thank you.
All right, went a couple minutes over. We're only on for half an hour, right?
Yep, that's the plan. Yeah, thank you so much,
All
Dr.
right.
Barker.
Thank you. Thanks a lot, Brett. Nice
Thanks a lot
chatting with
for
you.
having me. Appreciate it.